And we're back again with another video discussion about clinical toxicology. This time we'll be looking at flumazenil, corresponding to Antidotes in Depth Chapter A25 in Goldfrank's Toxicologic Emergencies. The learning objectives for this session are that you'll be able to explain flumazenil's mechanism of action in treating benzodiazepine toxicity and to outline a dosing regimen. Benzodiazepines are one class out of several that act at GABA-A chloride channels. Benzodiazepines enhance the action of GABA, increasing the frequency at which these channels open, allowing chloride influx into neurons. The extra negative charge hyperpolarizes the cells, making them less likely to generate and propagate action potentials, and resulting in CNS depression and sedation. There are several drug binding sites on these GABA-A chloride channels, and flumazenil is a competitive antagonist at the benzodiazepine binding site, thus reversing sedation from benzodiazepines. In the US, the common brand name for flumazenil is Romazicon, but there used to be a joke that it ought to be called Reversed, since it would reverse Versed, a common trade name for midazolam. So then, if somebody overdoses on benzos, then we should just give them flumazenil. No, it's not that simple. Flumazenil certainly can awaken patients with benzo overdose, but you are risking precipitating acute benzodiazepine withdrawal if that patient is benzo dependent. And who's most likely to have benzos around if they decide to take a drug overdose? Those people who are already on them chronically. And in acute care settings like on EMS rigs and in the emergency department, where the patient's history may be nothing more than the patient was found down, flumazenil should be avoided. Okay, but when might flumazenil be a good idea? The best antidotal role for flumazenil is to reverse iatrogenic benzodiazepine toxicity. As might occur with procedural sedation, this might occur, for example, with various endoscopic procedures which would be rather uncomfortable without sedation, and we'd be giving flumazenil to patients that we know do not have benzodiazepine dependence, so there's virtually no risk of inducing acute withdrawal, which could cause seizures and be life-threatening. If flumazenil is to be given to reverse iatrogenic benzodiazepine toxicity, here's the dosing recommendations from the Goldfrank chapter. Flumazenil is titrated slowly IV at a rate of 0.1 milligrams per minute. Doses up to 1 milligram of flumazenil should be able to reverse the amount of benzodiazepines given for procedural sedation. And the chapter, and I, give no recommendations for how to dose with an unknown overdose, since you shouldn't be giving it under those conditions. I have met another emergency physician who routinely gave dextrose, naloxone, and flumazenil to nearly every ED patient with altered mental status and a suspicion of overdose, and it made me very nervous. Well, that one was short and sweet. I'll be seeing you around.